Yeah, so my name's John Lewis. So I am a professor and chair at the University of Alberta in Edmonton, Alberta. I hold a chair called the Bird Docs Chair in Translational Oncology Research. The Bird Docs are actually a local group that fundraised for a prostate cancer research position. So they're a group of local men in Alberta that have been passionate about the work we're doing. I'm also the CEO of a spin-out company called Nanostics, and I'm going to be sort of spending our time today talking about sort of what the kind of research we do at University of Alberta in prostate cancer around the way we screen for prostate cancer in men and our work to hopefully improve that through the development and launch of a new test called ClarityDX Prostate. And as a bit of background, so I have a PhD in biochemistry. And I actually did some work in nanotechnology and have been sort of working for many years with sort of one foot on the academic side and one foot on the commercialization side, trying to bring new technologies or discover new technologies, develop them, and bring them to the clinic. So because of that, I have some disclosures to make. So I'm founder and CEO of this company called Nanostics. This is the company that has just launched ClarityDX Prostate. I've also launched several other companies from my lab as well, mostly in the area of cancer diagnostics and therapeutics. Okay, so I just want to start with, what science has contributed or what sort of the time we are in science now and just the amazing revolution that we've seen in what we know and actually how we can affect disease, I would say more than any other time in history. We can do things now we couldn't even imagine 10 years ago. We understand the way cancers develop in very, very minute detail, thanks to these amazing new high throughput technologies. It's funny, I made this slide about 10 years ago. Machine learning was just beginning to become popular. Now it's pretty much in every aspect of science, of drug development, and even healthcare delivery. We're able now to be able to really customize cancer drugs, not only for diseases, but even for individuals. Our ability to image disease inside a person is just unprecedented. There's amazing new techniques in MRI and CT and other techniques that are allowing us to see cancer better than ever. And of course, the development of and miniaturization of technologies through nanotechnology has enabled us to create amazing new diagnostics and therapeutics for a wide variety of different cancers. And so again, this is allowing for personalized medicine because every cancer is different, every person is different. Earlier detection, which I'll be talking a lot about today, and then ideally, all of this translates to better treatments and better patient care and better outcomes and quality of life for individuals. So I think this war was declared on cancer several decades ago now. It seems like a ton of money and effort has been put into cancer research, and pretty much every week, you see on your news feed that cancer's been cured in some way or another. But how is this actually affecting real people? And so I'm happy to say that, although we have invested a ton of money into learning how cancer works and new treatments, there's actually been a pretty substantial improvement in the way that we are diagnosed and survive from cancer diagnoses these days. So pretty huge impact. So breast cancer, obviously a ton of effort's been put into breast cancer research. Survival increased by more than 50% since the 70s. Prostate cancer death rates have fallen by 20%. And prostate cancer, there's been, a lag. Some new therapies have really come on the market in the last 5 to 10 years, and these numbers will continually improve. And the benefit of that is we're seeing a lot more survivors of both breast and prostate cancer, and many of the other cancers as well. So I do fundamental research in cancer, and so research can mean a few different things to different people. Research can be evaluating the practical application of new products or processes. Or it can be, and I think this is more apt to what I do, learning about the fundamental nature of things without specific applications or products in mind. And so this really differs depending on what your perspective is. So again, in my world, clinical research is when we've already developed a drug or a new test, and we're testing it on a patient population to see if it works better than what we currently do. Basic research is sort of what it's been, what I do has been traditionally called. Actually, scientists don't love the term basic research. It's very basic. So we've really recoined that term to fundamental research. What are the fundamental underpinnings of cancer in this case? And what I've tried to do in my laboratory is try to combine sort of fundamental and clinical research under this umbrella we call translational research. And I like to think of it as is research with a line of sight to the patient. And so typically, there's this paradigm around, how do we learn new things in the lab and eventually make an impact on patients? It's actually quite a long journey. So myself, I may be sort of hanging with my grad students discussing science and maybe experiments they're doing. So maybe we come up with a novel concept that we want to test in the lab. Typically, then I'll send that graduate student into the lab for 6 months or a year or 2 years to really test that idea to see if it's real. And that can take a long time, a lot of failure, but eventually may find something that seems like it could potentially be applied to patients. So then we take that and we apply that in clinical trials through a new test or therapy in patients with physicians and clinical trials folks in hospitals, et cetera. And if all of that works out, and it works better than what we currently have, then it's put into clinical practice. And this can take a long time and involves, this translational research. So the way I've sort of managed that in my academic career is sort of in 3 different ways. So I have, so my laboratory at the University of Alberta, our main interest, and I'll get into this a little bit, is the study of metastasis. So the study of the spread of a cancer that starts in one place and spreads somewhere else. And this is a very, very important process that really dictates how curable or incurable the disease is. And really focusing this on the development of novel tools to detect cancer earlier and metastatic cancer earlier, and developing nanotechnologies both for imaging cancers better and to treat those cancers as well. And so I have grad students and fellows that are studying the sort of the fundamental aspects of cancer in my laboratory. But we realized pretty early on, if we wanted to make an impact on patients, we needed to do translational research. So we founded the Alberta Prostate Cancer Research Initiative in 2013 with the help of this group called the Bird Dogs, and basically brought together a group of over 100 scientists, physicians, patients, healthcare employees, and then basically create an international collaborative network to be able to do, basically facilitate translational prostate cancer research, and really, with the goal, the sort of the high level goal of accelerating the translation of research that was really promising in the lab, but basically through the laboratory into the clinic. And as a result of that, we came up with several things that were particularly exciting. We realized that pharmaceutical companies weren't going to swoop down and take our technologies and put them in the clinic. We had to do that ourselves. So we founded a number of companies to be able to take these technologies and do clinical trials and hopefully prove that they worked or didn't work, and bring them to the benefit of patients. I'm going to be talking today about Nanostics. Nanostics is developed and validated now, commercially launched this ClarityDX Prostate test. So I'll quickly talk about sort of this network that we created to be able to facilitate this kind of research. The Alberta Prostate Cancer Research Initiative, or APCARI, is basically this multidisciplinary team of researchers, research scientists, clinicians, patients, industry partners, non-for-profit networks, and all the hospitals and diagnostic labs that sort of play a part in each part of our research. And the idea here is that we work together, because scientists can only come up with so many ideas if they aren't hearing the real world experience of patients, of physicians, in the clinic. It's really hard to actually work on a question that's relevant to patients, and vice versa. It's really important for clinicians to hear about what's happening in the academic lab so they can understand what's coming down the pipe or really fact check, ideas that are coming out of the lab. And we found this is a very productive environment, not only to advise sort of our academic fundamental research, but also to help us design clinical trials that can really make an impact on patients in the future. And so in Alberta, we've been fortunate to be able to, and actually there's, in Alberta, most of the population is concentrated in 2 cities. And so actually more than 90% of all the new prostate cancer diagnoses come in, basically 4 different institutions in 2 cities. And so we've created these clinical teams at these institutions to capture basically all of the new diagnoses of prostate cancer in the province. And this has been really important in our success in developing and now validating this new test. And we've been able to not only do some of our own work and bring it forward, but also collaborate and network with other efforts around the world. We have a great relationship with Prostate Cancer Canada and Movember, for instance, through the True North Project, where this is a network with 14 different countries and hundreds of institutions. And we've contributed almost 5,000 participants from Alberta to this, sort of large cohort looking at outcomes from prostate cancer. And we've looked at sort of many other studies looking at novel diagnostics and therapies, including our own ClarityDX Prostate test. I would say the other thing that APCARI has really contributed is the development of what we call a cohort. So again, men who were suspected of prostate cancer throughout the province of Alberta were identified by our teams and recruited into our study. We recruited now actually over 15,000 men in total. We have about over 2,700 participants that have given blood, urine, and semen and put it into our biobank. And we're using this not only to sort of validate some of the science that we're coming up with the lab, we've also shared these with many, many other countries, other labs and companies that have had really good ideas and have really, all they need is sort of high quality biosamples, whether it be blood, urine, and semen, to confirm their ideas or confirm their tests. So this has been a really great resource for many labs around the world. Okay, so that's what Abkari has done. And so I now sort of want to take it back to what we see the key problem in prostate cancer is and the problem we were trying to address through the development of this new test. So as you probably heard, prostate cancer is the most commonly diagnosed cancer in men, sort of after non-melanoma skin cancer. So it's pretty significant, 30%, 36% of all newly diagnosed cancers, 10% of all cancer deaths in men. It's pretty significant. I like to frame it as out of every 100 men, 16 will be diagnosed with prostate cancer in their lifetime. But prostate cancer is one of those diseases that you hear that you can live, or die with instead of. And that's only partially true. And the reason people say that is because actually, as you get older, the possibility of you having some prostate cancer is actually somewhere around 80%. So they've done these rapid autopsy studies where they looked at prostates, and many men harbor low-grade prostate cancer that just was never diagnosed. So the real question becomes not, do I have prostate cancer, or do I have prostate cancer that's likely to kill me? And so this is a pretty significant number. So 3 of every 100 men will die of prostate cancer. So 3% of the male population. That's pretty significant. And really the challenge is we don't really know which 3% are likely to die of prostate cancer. And we really want to get at this question of who is likely to have prostate cancer that they're going to die of, and can we develop and focus our efforts on those men to cure them. And so if we look at what is most deadly when it comes to prostate cancer, and this is true for many other solid tumors, the deadliest aspect is actually its spread or metastasis. So the prostate is sort of the small organ under the bladder, about the size of a walnut. Again, if you're diagnosed with prostate cancer that's in your prostate, we treat it very well in North America. So the average 5-year survival rate is pretty much 100% for localized prostate cancer that stays in the prostate. The issue is when it spreads. And so prostate cancer spreads, throughout the body. You can go to the soft tissue, the lymph nodes, typically the bones as well. And for metastatic cancer in North America, the survival rate drops to about 30%. And this is in North America where we treat, prostate cancer pretty well. In many other countries, this is well below 10%. And our current diagnostic tools do not do a good job of predicting whether metastasis is likely to occur or even whether it's occurred. And our current treatments, although they're improving, do not prevent or cure metastatic disease. So this is really what my academic lab is focused on, to develop better tools and treatments to address sort of this key switch between localized and metastatic prostate cancer. So if we think about so this challenge in screening is a real one. So while many men may have prostate cancer, only a certain number have a type of prostate cancer we really want to treat aggressively. And this has been a challenge for the physician community and for men and their doctors to figure out if they want screening, and then if they've been screened, what to do about the results. And again, this is just another way of presenting the numbers. So again, these are the Canadian Cancer Society numbers. In Canada, the percentage of all new cancer in men is about 20%, and about 10% of all the deaths in men from cancer to prostate cancer. But you can see the cancer is huge morbidity in Canada. 28% of all deaths were due to cancer. So prostate cancer, again, is very treatable at the very early stages. So we know that early diagnosis is critical, because once it spreads, it becomes very difficult to treat. And typically it'll go through sort of this spectrum. So again, if you have localized prostate cancer, you get it treated through surgery, radiation, hormones, chemotherapy. Some percentage of the population who gets treated, roughly 30%, will have what's called biochemical recurrence. So in this case, this means that your PSA levels, prostate-specific antigen levels in your blood, when you take your prostate out, should drop to 0. And so it should stay 0 for the rest of your life. If the PSA levels start to rise again, this is called a biochemical recurrence, that means you have some prostate, some prostate cells left. And if you've taken out your prostate, that can really only be cancer. So it means your cancer is coming back. And so we continue to treat that. And typically with hormone treatments, and we have some really nice hormone treatments now, and it'll become eventually resistant to these hormone treatments and either stay in the prostate but resistant, or become metastatic and be resistant. Then it becomes very hard to treat. So when it's resistant to these hormone treatments and it's spread through the body, again, this is pretty much an incurable disease. And so we want to avoid getting to this stage if possible. So how have we, there's really been a revolution in screening, and I mentioned the PSA test already. So PSA testing, it's a very simple blood test. It's a single protein called prostate-specific antigen. It's supposed to be in your prostate. It's not supposed to be in your blood. So if you detect it in your blood, something's going on with your prostate. And so when we started screening for PSA in the late 80s, early 90s, we saw a huge incidence of newly diagnosed prostate cancers. And these were mainly prostate cancers that just went undiagnosed because there weren't any symptoms. And these included some very advanced prostate cancers, but also very early prostate cancers. And I'll get into that in a bit. And so the result of this huge, this increase in PSA screening was, again, at this huge spike of diagnosis of undiagnosed cancers. And this had a pretty dramatic effect on survival. So the mortality, the survival from prostate cancer improved significantly, as I mentioned at the beginning. But once we got through these original, the undiagnosed prostate cancers, the incidence is really high. And we'll see this has been a bit of an issue, except for the fact, I just want to make the point, these are Canadian specific numbers. When we started screening for prostate cancer, we saw a huge improvement in mortality of prostate cancer. So men were surviving much better their diagnosis of prostate cancer. And so screening has had a really positive effect on reducing the number of men who die from prostate cancer. And this cannot be ignored. And if you look at prostate cancer screening compared to some other screening, this is kind of a complicated slide, but basically the message here is when we look at different ways of screening, colonoscopies, mammographies, PSA, lung CT, which is an imaging scan, and whether we gain lifetime or lose lifetime based on the screening on the average of the population, PSA screening actually does pretty well. So it definitely gains lifetime, and better than mammography, for instance, which is basically almost a coin flip. So again, prostate cancer screening overall has gained significant lifetime for men, and so PSA performs as well or better than nearly all widely used cancer screening tests. So these are all arguments to use prostate cancer screening. And the takeaway from this data is basically prostate cancer screening with PSA testing reduces prostate cancer-related mortality. This is the data says this very clearly. So why is this under debate? Why isn't PSA screening been widely recommended in the past decade? And so we'll get into the kind of the reasons why. And I'll be pretty bold in when I say this. This is a slide I usually incorporate in my deck, because PSA screening alone, while it detects, some cancers that need to be treated, causes unnecessary harm. And it's really been a challenge. And the reason for this is because the PSA blood test, while it's pretty good at detecting cancer, is also pretty good at detecting lots of things that are not cancer. So we do a lot of PSA testing every year, 30 million PSA tests every year in North America. But it's actually one of the worst tests we've ever brought to the clinic. Up to 85% of all PSA tests are what we call false positives. What that means is that if your PSA is elevated, you actually have an 85% chance that you don't have cancer. And the challenge is to diagnose prostate cancer definitively, you need to have a biopsy. And a biopsy, for all of those that have had it, and even, as I describe it, it's a pretty invasive procedure. So transrectal ultrasound probe, 12 needles or more pressed, between the legs, through the body into the prostate. So obviously a very uncomfortable, potentially painful procedure that can come with a pretty substantial chance of some kind of infection. This infection can, progress to life-threatening sepsis. And I think if you have aggressive prostate cancer, completely worth it. But the problem is that most biopsies result in either negative or what we call indolent prostate cancer, which means the prostate cancer that you could live with your whole life and not even know you had and have no chance of dying. So this is really the issue, over biopsying and then over diagnosis of prostate cancer. And this is really what task forces have been, struggling with, looking at this data for PSA screening. Because of the lack of specificity of the PSA test, there's a pretty high burden of investigation. So we're investigating, this 85% of high PSAs that are not cancer. And then we're overdiagnosing what we call this clinically indolent disease. So this is prostate cancer that is identified as prostate cancer, but you could live your whole life and not worry about it. And with the diagnosis of prostate cancer comes this, I have cancer, many people are saying, I want to have surgery, I want to have radiation. And what we know is that, we're over-treating a lot of cancers to get, importantly, the ones that actually need treatment and will save lives. And so as a result of sort of this balance between screening and then overdiagnosis, the different task forces over the years in the past decade, in the US have given PSA screening a grade D recommendation. So moderate to high certainty that the harms of PSA outweigh the screening benefits. And in Canada, the CUA guidelines, we recommend not screening for prostate cancer with PSA tests because of the low to moderate quality of evidence. And so I would say, you can see their point, but this has had a dramatic, I would say, negative effect on our ability to detect prostate cancer because, and this is just a different way of showing the data I showed before, once prostate cancer becomes metastatic, it is a much more deadly disease. And we've seen in the last 10 years, since we've been reducing PSA screening, we've actually seen the mortality curve tick up. So more men are dying of prostate cancer than before these recommendations. And so this to me is completely unacceptable. And so this is just the Alberta guidelines, and these differ depending on what province you're in, but generally fit men between the ages of 50 and 75 with at least 10 years of life expectancy should be made aware of the availability of PSA, but also aware of the risks and benefits, which I think is a reasonable approach. But then again, it becomes a decision between your primary care physician, you as a person, your level of risk, and I think, ideally we just need better information so that we can make a better decision about whether to proceed to a biopsy and what comes after that. And so this is a bit of a sciencey slide, but this just demonstrates sort of from a pathology standpoint, really there's two different kinds of prostate cancer. Some are lethal, some are not. And so when a pathologist, get a biopsy and the pathologist looks at your biopsy, the way your prostate looks, they can classify it into these different 1, 2, 3, 4, 5 classifications. And if you're 1 or 2, your chances of being alive in 10 years are almost 100%. If you're 3, 4, or 5, your chances are substantially lower. So we want to distinguish between these 1s and 2s and 3, 4, 5s. And currently the PSA test does not do that. And really to make a better decision about whether you actually need a biopsy or not, if we could determine this before, then we do biopsies and concentrate on those men, we have a pretty good chance of having this higher grade prostate cancer. So our goal then is, number one, we want to preserve the mortality benefit of prostate cancer screening, obviously, but ideally we want to reduce overdiagnosis and overtreatment. So how do we get there? I think the hurdles are, and again, for overdiagnosis, we want to reduce the number of men being diagnosed with low-grade clinically indolent disease, and overall reduce the number of biopsies performed. And then on the overtreatment side, reduce or eliminate the treatment of low-grade clinically indolent prostate cancer. Because obviously treatment of prostate cancer comes with potentially significant side effects, which if it's going to save your life, may be worth it, but if they're not going to have an impact on your life at all, definitely not worth it. So if we look at the way we screen for prostate cancer now, again, we have the shared decision-making, and these are the US guidelines between 50 and 70. If your PSA is low, under 1, repeat testing every 4 years. Your PSA is sort of in this gray zone, 1 to 3, repeat testing every 2 years. If the PSA is over 3, and this is nanograms per mil in the blood, then more frequent PSA testing is indicated, where you may do multiple tests over a short period of time. And if your PSA continues to be elevated, then consider adjunctive strategies. Now, adjunctive strategies in this case are additional biochemical tests or imaging like MRI. And if all of these indicate there could be something abnormal, then biopsy shared decision making. So you can see here, there's a lot of sort of gray area here. How many PSAs you do, what other strategies do you look at? Do you do imaging? And a lot of this is a bit of a black box and more of a discussion between physician and patient about whether to get a biopsy. So if we can get a more accurate test at this stage, then we can achieve this biopsy avoidance goal. And so, so we spent the last 12 years basically looking at this question and trying to develop a tool that could be used at the PSA screening stage to be able to better inform the decision about whether to biopsy or not. And so we developed this test we call ClarityDX Prostate. And as I'll get into, it's a pretty simple test that that we fit in right through PSA screening. So we're still suggesting to do PSA screening. And then for those men with that higher level, over 3 nanograms per mil, you typically do a repeat PSA anyway. And in that case, we do ClarityDX Prostate, which includes repeating the total PSA, doing a second test called free PSA, and including some clinical features that I'll get into, and running a machine learning algorithm that substantially improves the accuracy of deciding whether you have high-grade cancer, and then you can make a decision to proceed to MRI or biopsy, or to not proceed and continue monitoring. And so what is ClarityDX Prostate? So this is the complicated version. I won't spend too much time on it, but I'll get into more about how we developed it. So again, we tried to develop a test that was pretty simple, but that provided substantially better information. So we're using total PSA, which is the same as the regular PSA test we all get, and then incorporate a sort of a variation of that called free PSA, which is routinely done in the US, but not Canada. And then incorporated 3 clinical features, so age, digital rectal exam findings, and previous negative biopsies, which is either yes or no. We've created, and I'll tell you why this is really important, we've created, through a very large study, created a machine learning model. So we've basically done sophisticated math, combining all this information together, and in the end, spit out a risk score that has a pretty good accuracy, as I'll show you, of your probability of having over number 2 grade prostate cancer, and where a biopsy would be suggested. And we called this test ClarityDX Prostate. And so basically, in very simple terms, it measures total PSA, it measures % free PSA, combined with age, digital rectal exam, previous negative biopsies, in an algorithm to come up with a score. Now, so with any machine learning algorithm, it's really, so its accuracy relies on tons of really good information going in, because what machine learning does is identifies patterns that you just can't see by eye, that a human can never pick out, and is able to see these patterns in large amounts of data to come up with more accurate predictions. And so to create this machine learning algorithm, we did sort of a gold standard prospective trial, multi-center international trial. We recruited almost 3,500 patients from across the world. So we had, Johns Hopkins in Baltimore, we had UCLA Health in Los Angeles, along with our 2 sites in Alberta. We even got a European site in the Czech Republic, both to create this algorithm and to validate the accuracy of the algorithm in the real world. And so we were really pleased to see, we got this data about 6 months ago, when we implemented, when we looked at the accuracy of our new ClarityDX Prostate algorithm to predict high-grade prostate cancer, so prostate cancers in the pathology that was high, 3, 4, and 5, it was substantially better than PSA screening alone. So it turns out it was 3 times more accurate than PSA screening alone to predict what we call clinically significant prostate cancer. And using this trial, if we were to incorporate ClarityDX Prostate in the way I showed you, after a high PSA test, we could reduce the number of unnecessary prostate biopsies by up to 35%. Now, obviously, this number is really dependent upon that, how well physicians use it and how well they follow it. But if they follow the results exactly, then we can reduce biopsies up to 35%. And so we're really excited about this because this is a pretty simple test to implement. The equipment, the instruments to do PSA and free PSA are pretty much in every diagnostic testing lab in the world. And it compares very favorably to some other tests that are on the market. So there are other tests on the market that are available now. And for one reason or another, they're not even suggested to be used in Canada. That's mainly because of cost. So I'll highlight the 4K score. Is another blood test that's pretty simple. The turnaround time is about 7 days. It's accurate, so it's equivalent accuracy to ClarityDX Prostate. And the issue really is cost. So the retail price is over $1,000. And the reimbursed price in the US healthcare system is pretty substantial. So, over $600. So it's been a real challenge to incorporate 4K score into routine screening. So again, particularly in the Canadian environment where we're much more cost prohibitive, ClarityDX Prostate, we get turnaround time is very short, under 24 hours, can be as low as a couple hours. Accuracy is just as good as any other biochemical test. The cost, because there's a machine learning component, is it's much lower, and it makes the ease of adoption pretty easy because we can do the test at any accredited lab that has a PSA machine, and then we can run the algorithm on our secure server. And again, it's obviously substantially better than PSA alone. And there's a few other tests that are just not as good in accuracy. And ExoDX, for instance, is a very promising one, but it requires a urology visit and collecting the urine at a urology visit. All these other tests can be done at primary care, which I think is important to avoid the biopsy. So we're very pleased. So we got these results 6 months ago. We launched the test in Alberta, Canada, 3 weeks ago now. And so we're basically piloting in Alberta. We're going to expand out across Canada and eventually throughout the US in the coming months. But basically how we're positioning it as far as the patient and physician. So patients will present at their primary care physician with their routine checkup and get PSA screened. And then the physician basically will complete the patient information, physician information, clinical information on the ClarityDX Prostate requisition form, which is available on our website, including the results of the DRE. And then in Alberta, there'll be a patient provider section of the DynaLife. So DynaLife, Alberta Public Labs, are basically all over Alberta, can collect blood for the test. And this is done through a requisition form. And then these two forms will be then taken to any DynaLife APL lab for sample collection. And then the results will be processed through the DynaLife APL group and the Nanostics lab, and then the results be sent back both to the patient and the physician. And so we worked really hard to create a results score that's very, very straightforward and easy to interpret. So again, the details are that we have a test report, basically provides all the detailed information. So what's the total PSA, what's the percent free PSA, and then the overall ClarityDX Prostate risk score. The risk score is basically a percent probability of this higher grade cancer, 3, 4, and 5. And was reported basically associated with their age group. And a risk score of 25% or higher indicates a higher risk for clinically significant prostate cancer. So this is prostate cancer that you likely want to get followed up either through MRI or biopsy. And so very clear report score here. And again, if this patient is in the red zone, then they're classified as high risk. It's pretty easy to have this discussion, look at the data, look at your scores for PSA and free PSA, and to help you make a decision. And so I mentioned that ClarityDX Prostate has been launched in Alberta. So again, patients can access the test at all APL. Actually, it was just changed the name from DynaLife collection sites in Alberta. We're currently not reimbursed by the healthcare system, although that is definitely a goal for us. So it's currently available as a private pay test, not covered by Alberta Health. It may be eligible for reimbursement through a health spending account. We've launched the test for $300 Canadian, but we're discounting by $200 to make it $100 as an introductory price as we roll it out. And again, we're available in Alberta. The goal in the next few months is to expand out across Canada and out across the US as well. So to sort of summarize in the next 2 slides, so we've developed this novel test, starting basically from the lab, taking all the way through clinical trials, and now to commercial launch, ClarityDX Prostate, before prostate biopsy. Our data clearly shows that it decreases the number of unnecessary biopsies by about 30%. It decreases diagnosis of low-risk prostate cancer and increases diagnosis of significant prostate cancer. So we think it would be an extremely useful tool, both for men and their physicians, to make better decisions about how to act upon prostate cancer screening. And again, we think, generally for physicians, what we're recommending now in the light of having better tools, keep PSA testing, and then prescribe ClarityDX Prostate for men with elevated PSA, and obviously refer men to urologists for further screening, if you're in the high-risk group. So if you want to know more about ClarityDX Prostate, we have a website, nanosticsdx.com. There's a button there to get more information about the test, to look at all our data, look at all the references and pull out the papers if you're that inclined, and basically to have that conversation with their physician. So on to there again. So I feel very strongly. So we launched this in Alberta first. I would say, I just want to say that we've had incredible support internally from Alberta, from Prostate Cancer Canada, Prostate Cancer Foundation, Movember, Motorcycle Ride for Dad, many of these research groups, and of course, federal funding as well. So we've launched the test in Alberta first. We firmly believe, based on our data, that every man should have access to this. So it ideally should not be private pay. So we're really keen on generating the data and making the argument that this test should be reimbursed, not only in Alberta, but across Canada. So that's really our big effort now as we launch the test to look for reimbursement. And with that, also just want a huge amount of people that contributed to the development of this test. We have these amazing, clinical teams in the different centers in Alberta, and some fantastic people that have sort of worked day and night over the many years to put the clinical data together to make sure it was high quality. And just a fantastic team of scientists as well that contributed to the basic science behind, the fundamental science behind these advancements. So really appreciate your attention today, folks, and happy to have a discussion about anything I talked about.
Thank you so much, Dr. Lewis.